Okay, so it's 8 o'clock, and welcome everybody to another episode of Marvelous Medicine. Today, Shyam and Kavi are going to take us through their work with artificial intelligence and informatics on tracking COVID-19 and how it can be used to predict which patient is likely to get sick or who's likely to get long COVID. Um, so we thought it's something topical, and since by and large in Marvelous Medicine we've been trying to avoid talking of COVID other than the vaccine session, because there's so much of information overload and there are a lot of depressing news. But nevertheless, we thought this is an important thing as a follow up to the talk on artificial intelligence that Sham gave. So those of you who have already attended know about Sham. So I'll just briefly tell you that he's an associate professor of biomedical informatics at the University of Pittsburgh. He did his MBBS from JIPMA Pondicherry and his MS Physiology and Biophysics from University of Illinois. Did his neurology residency from Boston University Medical Center, and eventually landed up in artificial intelligence after he did his MS and PhD from the University of Pittsburgh, where he continues to work. Joining him will be Kavi Vagholikar, who's an assistant professor of medicine at Mass General Hospital. He did his MBBS from Grant Medical College and his PhD in scientific computing from Pune University. As the topic has a lot to do with virology as well as community medicine, I thought we should have two people moderating the session. One is Dr. Ravi, who's the founder and retired head of Department of Neurobiology at NIMHANS, currently the nodal officer for genomic confirmation of SARS-CoV-2, Government of Karnataka. Dr. K. Narayan was our teacher in preventive and social medicine. After a long innings at JIPMA, he worked in a teaching institution in Malaysia and is currently based in Coimbatore. He's also very much interested in data collection, and in fact, he's devised a software for tracking all his classmates and alumni. So you can just click on their name and you'll know everything about them. So what I mean to say is he also has a background in informatics. So over to you, Shyam, and hope to get enlightened.
Okay, can you see my first slide?
Yes.
Okay, so what we're going to do today is I'll talk for around like 15-20 minutes, and then Kavi will come on and talk for another 15-20 minutes, and we want to leave quite a bit of time for people to kind of ask questions and ask more information about what this is all about. One of the things that we would like to do is be able to expand what we're going to talk about today to India. And Kavi has already been working in expanding this to Pune. And we're hoping that we can expand this to maybe Chennai and other places. So that's kind of one of the goals of this talk. So I'll talk about kind of two pretty big projects. One which has been going on for a while, for about 4 or 5 years now, called the ACT network. And then the more recent consortium called the 4CE, which was specifically set up for COVID. So the ACT network, which basically stands for Accrual of Patients to Clinical Trials Network. So this is basically funded by NIH, by an institute called NCATS. And the goal here is to use electronic health record data, such as the EHR data, for purposes other than clinical care, especially in this particular case for identifying patients for clinical trials across the United States. And then more recently, over the past year, we have been using this network to understand some of the features and characteristics of COVID-19. And going forward, we want to use it also to understand some of the long COVID issues. So one practical concern is that EHR data is difficult to move out of the hospitals due to ownership and privacy concerns. And this is true in the United States, and it's true in also many other countries, including India. And so technically, the way the Act was set up and continues to work is that it's a distributed network of EHR databases where data have been cleaned for research. And so that way, the data doesn't have to move out of the hospitals, but can still be used for research across the country. So a little bit about the technology. So there are two pieces of software which are used to run the ACT network. So one is called I2B2. So this was developed at Harvard Medical School, and Sean Murphy is very deeply knowledgeable about this. And Shrine is another piece of software. So the I2B2 software is the data repository, which is located at every hospital that participates in this network. And the EHR data is cleaned up and fed into this I2B2. It's basically a database, like an Oracle database or a SQL database, which has been formatted in a certain way. And so all the data resides in this I2B2. And Shrine is the connecting software through which any person can use a web interface. So it's basically got a web-based interface. You log in, and I'll show you how it works. And you can issue queries into this network. And what Shrine does is that it will broadcast these queries through a central hub, which is located at Harvard. And that passes these queries to all the I2B2s across the country. And the query gets run. The results basically get transferred through the hub back to the person who issued the query. And all of this happens in real time. So usually you can issue a query and within minutes actually get back typically patient counts which satisfy your query within minutes. So the current status of this network is that we have about 42 hospital systems. These are mainly university and academic hospital systems, which are connected to this network at this point. And so there's about 130 million unique patient data that you can query on this network. So that's pretty much a little bit more than a third of the US population is now represented in this network. And then we have a few more lined up who are going to be hooked up to this network. So this is how it looks. So you basically go to a particular URL, and then if you have credentials, which is a login and a password, you'll be able to get into it. And then when you log into it, what you basically see on the left-hand side is all these various things that you can use for constructing the query. And we call this the ontology, and I'll get a little bit into the details of this. So for example, if I want to construct a query, I just want to know like how many people there are across this network who are say between 35 and 44 years old, and also have a diagnosis of diabetes mellitus. So what you basically do in this case is you drag the appropriate terms. So in this case, you would drag this age group into one of these panels, and then you can drag this ICD-10 code, which represents diabetes mellitus, and then you basically hit run query. And this is a very simple one. And then you can see here within minutes that you start getting responses back from these various universities, which tell you how many patients there are which satisfy this criteria. So like you can see University of Minnesota says there's 130,000, University of Pittsburgh, 21,000, so on and so forth. And they all get listed here. And you can make more complicated queries. I'm just showing you a very simple one. So this is basically getting a little bit more into the details of what are the things that you can actually query. So these are all standard terminologies that are in use. And we have essentially created a whole big list of all these things that you can use to construct your queries. So you have basically ways of representing demographics, which is critical for most research questions. And then diagnosis, we have both ICD-9 and 10 because till a few years ago, diagnosis was coded with ICD-9, and now we've shifted to ICD-10 in the United States. Lab tests are usually coded with a terminology called LOINC. Medications are coded with a separate terminology called RX norm. And then procedures have a whole set of different terminologies. So there's ICD-10, there's CPT, there's HCPCS, as well as the older ICD-9. So there are like 4 terminologies in use for procedures. And then there are some details you want to know about the encounter that the patient has with the hospital system. Is it an outpatient, inpatient, so on and so forth. And then a year ago when COVID came in, we added this COVID ontology so that people can use this to query COVID-related questions. So this basically is just to show you that these are the areas that you can query. You can do demographics, diagnosis, laboratory test results. And now we have this COVID-specific things, medications, procedures, and visit details. Now this doesn't cover all kinds of clinical data that a patient has, but it gets to a pretty large chunk which are useful for doing exploratory research. This is just showing you that these are the, so each of these terminologies is like a tree which can keep expanding, and it will list in greater and greater details concepts that are available. So like for COVID, we have things which are related, concepts which are related to course of illness, diagnosis, lab testing, then treatment, as well as there's a way to get to the total patient count. And so this is basically showing you what happens when you expand it further. I'll just give you one example of things that, say, you might be interested in with COVID related. So one of the things we are interested in is how many people get severe COVID. And one mark of having severe COVID is that you might be on mechanical ventilation. And so what we do is that to make it easier for people to essentially figure out whether someone had mechanical ventilation, we'll collect all the codes which relate to mechanical ventilation so that you don't have to do this yourself. And then you can just use that. And then that will do the proper aggregation. So here we list all the ICD codes, the DRGs, which are kind of billing codes in the United States. And then there are these procedures like CPT and ICD-10 PCS, UMLS codes. All these get listed under that. And so the software basically does the work for you in this case. Okay, so I'll briefly shift over to 4CE, and then I'll come back and try to show you a live demonstration of the ACT network. So 4CE, as I mentioned before, was a consortium started at Boston. And this is an international consortium compared to the ACT network, which is a US network. And this consortium was basically, the idea here is to leverage, again, EHR data at a very large scale to get some handle on COVID. And so here is the URL, which is a website for this consortium. This consortium also leverages this I2B2 technology. So essentially, sites which have their data, the EHR data and I2B2 is what we require. And then we can do this distributed analysis. So the data itself will stay at the institution, it never comes out. And then there's software like written in Python and R code, which gets distributed, and those get run locally at each site, and then the results get aggregated. So here you can see that we have a whole lot of sites in the United States under this consortium. There's also a bunch of sites in Europe. There's one site in South America. There's also one site in Singapore from Asia. And most recently, Kavi will talk about that we are trying to stand up a site in Pune for this consortium. And here's an example of the kind of work that this consortium has done. And most of these are out as preprints, and eventually they'll start getting into journals. So here is an example where we compared laboratory trajectories across 342 hospitals in 6 countries for hospitalized COVID patients, basically. So this looked at 36,000 hospitalized patients across these 342 hospitals across all these countries. And one of the things that came out of the analysis was that at the time of admission, if you measure D-dimer, C-reactive protein, and lymphocyte count, they're pretty highly predictive that you will have severe COVID down the line. So here is the ROC, which is a metric which tells us how good these kinds of information are. So if you use only one of them at a time, so like say if you use only lymphocyte count, then the area under the ROC curve is 80%. So the best you can get is 100%. And if you use only D-dimer, it's actually maybe at around 0.75 or 75%. And if you used C-reactive protein, it's pretty high, 90%. But if you put them all together, then you can reach 90 to 95% in the first couple of days. So if you looked at just these 3 laboratory values and they were abnormal, and in the first couple of days, then the prediction power is pretty high. And then over time, we are showing that it starts to decrease. So the longer you are in the hospital and you don't get into severe COVID, then the less likely you would get into severe COVID. But at the time of admission, these are pretty highly predictive. So this is just one example of the kind of analysis which is going on, and we're leveraging just the large amounts of EHR data to be able to do this across continents. Okay, so let me try and do a demonstration of the ACT network. And as you can see, this looks very similar to what I had on the slide. And so you can keep clicking on these things and open it up. So let's say we want to do something like, let's say we want to find out how many people there are who have positive COVID test based on the nucleic acid test. And let's say, and let's say we are interested in females. So this is basically a simple query, which is going to essentially say, find out how many people there are on this network who had a positive COVID test at some point and were also female. And then you basically hit run. You can see that in real time, it sends this query out and it says I've sent it. And then you start to get results back. So some of the sites are still working on some of these things. So sometimes you get an error back. But generally, within a couple of minutes, you'll start to get back these numbers. So this is kind of the simplest use of this network, is you just want to get counts of patients which correspond to some query that you're interested in. And you can put in all kinds of things here, medications, so on and so look at what was, say, the prevalence of stroke pre-COVID, and what was the prevalence of stroke post-COVID. It's a more complicated back, and you can calculate those kind of things. Probably working on it. So all this runs across over the internet, and sometimes some sites might be a little bit slow or they're down, but generally this is up and running 24/7 throughout the year. So I think I'll stop there, and we can probably just move over to Kavi's presentation, and then we can come back to questions.
Yeah, I'll just put up my slide. In the meanwhile, maybe I should just ask Sean to make a few comments. He's on the call. Sean, would you like to make a few comments while I set up my screen?
Sure. I mean, thanks, Shyam. And I think that, we can see the power of this method. You don't have to have standard hospital data. So I think Kavi will show, but what's really important to emphasize is because you have those very flexible way of calling, your data different things on that left-hand side, you can actually put any kinds of data that gets collected into this query tool, and it will do a query based on any kind of data that you're collecting. What's important is that someone or some organization manage what you call the data, that terminology, and then that when the data gets coded at the hospitals, that it gets put into that terminology in the database. But once you do that, you can actually use this query tool for your specific kind of terminology that might exist in India. And that, gives you the ability to look across hospitals, but in a very private way. So you notice when Shyam was showing you a lot of those statistics, it would say plus or minus 10. And what it does is it purposely blurs the data a little bit so that you can't find anything out about one person. You can only find things out using that query tool about larger groups of people. Now, of course, if you have the permission and you go into the database that's behind that, you can find out, all that you need to find out about, anything. But then you would have to have those special, very special permissions to get into the database to do that. So at the level of that query tool, it protects patient privacy by blurring the data just a little bit to prevent any one patient from being kind of singled out and looked at with the tool.
Okay. So maybe so let me talk about the India context, right? So so during this time when COVID was happening, I happened to be in India for family reasons, and I was on this 4C consortium calls, and everybody used to ask me, Kavi, what's happening in India? And I wouldn't have anything concrete to share because the situation was actually similar, that all over the world researchers felt that the governments are publishing data about who's being tested. I mean, how many people are being tested, how many are positive, how many are dying, but there was very little insight about the clinical picture. And that was the motivation for the 4C consortium to come to build up this clinical picture. So I was in India, reached out to many hospitals, and so I'll describe what the challenges were, right? So things are a bit different in India, unlike in the West, where you have the research machinery well set up. And by India, I mean, the rest of the world. So you have US, Europe, and the rest of the world. So what happens in US and Europe is that you have a very good research machinery. You have hospitals which are heavily using electronic medical records. You have computer science teams, and all of them understand research methodology well, and they're churning out publications and papers. Right? But when you move to the low research settings, the hospitals primarily focus on care, on giving care. And the computer science departments are typically in some university. They usually don't interact with the hospital. So doing this kind of a work, this kind of work coming is a challenge. because they have not previously worked before and worked with each other before. And also, what happens in India uh, is the clinicians. Clinicians. The traditional role is they're heavily involved in care. There's huge patient volumes, and very little effort or inclination for the bigger population to a set of clinicians to do research. And research is typically equated to data collection, but research is more than data collection, right? And that cultural shift is little bit is coming in India, but it's still not there. So those are the main challenges. Okay, so I've just put this figure here on the left, but what does it mean? If you just take city of Pune, the population is equal to that of Massachusetts, the state in Massachusetts, right? The population of India is a third of that of the United States. Sorry, three times that of the United States, but almost a third of the land space. So density is high, the numbers are huge. Uh, so research which happens in the West may not be applicable to India. That's one point. Secondly, the research you do in the low resource setting is much more impactful than research happening in the West, simply because it's generalizable to that local population, right? So why is it that we are not doing this kind of work in India? And that's what I wanted to explore, and we talk about how to resolve, how we together can improve that, contribute to improving that problem, that solution. So these are just the numbers, and this was like last month, and we could see that the Indian graph is rising. And if I go in May, it surely would have shot through the through the screen on top, and which is probably what's happening now. Okay, so here is what we said. uh, um, uh, so in Pune, the municipal corporation, that like what is the town council was collecting data from hospitals. There were about 80 hospitals involved, and they're using a phone app which was deployed. Some of the hospitals were contributing data from the EHR. Most of them were having the phone app used, and these were nurses and doctors, next to the bedside of the patient, putting that information in the app. And this was flowing into the data center for the Pune Municipal Corporation. And so we uh, put together a team of computer scientists from institutions in Pune, from the university, from the teaching colleges. And so we had to first of all have this governance construct, right? So this is research data, this is patient data, you need to have a research protocol in place. So who is going to be the host for doing this analysis? Is it going to be the municipal corporation? They have never done this before. How do they do it? Is it going to be the university, or is it going to be one of the hospitals who's contributing data? And that has been the main challenge. So what we have done is, we have uh, first of all, we got a protocol, and we got one of the leading hospitals approve the protocol. That happened like in a week's time, immediately. But then the next step comes is that you need to have one of the institutions be the coordinating center, and there needs to be data use agreements need to be signed, so that the data is collected at that place, and that's where the research happens. So that has been a challenge, and we are still working on it. We are very hopeful of solving that pretty soon. Okay, but what is the idea? What is the goal? How can we help with the COVID situation right now? So imagine that you have data flowing in from one hospital or many hospitals into one area, and then we de-identify it. We call it a limited data set. What can be put into I2B2, and then we can make that available via I2B2 to the query staff, to the we can make dashboards for public health. So these are like the town, municipal commissioners, and the staff can actually look at it and get real time understanding of what's happening. And obviously you can share the analysis with the consortium to validate the findings, whether they're really generalizable to other areas. And we can build machine learning models from this data to actually in near real time help giving a decision, and help triaging patients at the point of care. It's very ambitious what I put over here, but at least what we can do is get some insights about what makes a patient severe, and help with that. Jump a little bit of slides out of time. So here are like the broad themes we evolved out in this group in Pune. One is So I happened to uh, visit the war room, at the corporation, where patients who are not getting beds were calling, and I looked at the process of how they were triaging. uh, and part of that was they just had one variable in place, that what is the SpO2, and if the SpO2 was below a cutoff, then they would get a bed. If not, they would be managed at home. And one could quickly see, as the number of patients would rise, that one variable was not enough. There are going to be more patients who need a bed than that. So what can we do to quickly help them, give a second variable at least to help triage? So that is a goal of the analysis. So that can directly help with bed management, just by finding out what is that second variable which can help. Secondly, is that you all must be knowing about remdesivir, like how it is used, and we don't objectively know how, whether severe patients are getting it, whether moderate, what kind of patients, how is it being used. So having the system in place can help objectively answer that question, and can help control the supplies of remdesivir. And also it can help project how many beds we need, how many ventilators we need, and so on. And one of the important goals, I mean, the most important goal of all of this is to minimize mortality. So which are the subsets of patients who really become bad, or which are the subsets of patients which go home and then come back with complications? So finding that set, which has high mortality, can really help. So we have electronic health records being used in hospitals in India. We have the best computer science, expertise available in India. Then why are we not able to do this, right? And I think the answer to that is simply that we have not done it before. And I hope that towards the end of this call, you all feel why, we all end up with the question, why has this not happened before, right? And because it's so easy, it's so straightforward. When the resources are there, why is it not happening? Okay, so this is like the basic. So coming to the ground level, you don't need to have all of your EHR data for all the patients in this data repository. It's your own data repository. Your data doesn't leave your hospital. So you create a data store database in your hospital with some, at least, these basic uh, uh, variables which are relevant for COVID. Right? This is a minimal set. This is a set actually from Pune. And obviously you have the act ontology which Shyam described. You can add on more variables. So this is a dictionary of elements. What's critical is the labs, the medications, and the transitions. Symptoms, it's okay, like, but with labs alone, like Shyam showed, you can predict who's going to become severe. And imagine if this was available a year ago, and if you have this running at a district, at different hospitals in a district, and if they can be connected via Shrine, how helpful it would be for objectively deciding on COVID therapy, and not just COVID, whatever future pandemic, and not even pandemics, even for chronic disease management. Right now, we don't have any data, but what's emerging is electronic health records are getting deployed. We know that it's well known that they are very noisy. They are not as good as data which is collected via surveys for epidemiology, to a certain extent, but the lab data is very objective, right? Uh, so our focus is getting the lab data in first. If we can get medications, that's fine. Symptoms are not there, it's okay, but I think we can do a lot with lab data, and with knowing the transitions alone. um, okay, and as Sean mentioned, the most critical part of this collaboration is that no patient data leaves the hospital. It is inside your firewall. 4CE shares with you this resource about the software, the I2B2, the scripts, this analysis that they've already done. And it is your in-house team or your collaborators, the computer science collaborators who will come and access your database and work within your institution. And you leveraging this framework and being part of the consortium, getting this expertise, this project will happen. I'll not go into this. So we've kind of come up with suggestions about how to really secure the data, even working with Amazon. So Amazon has created the data infrastructure to really help that collaboration happen between a computer science department and a hospital, just because we don't have that security expertise in place. So that help is also there. Yeah, I just want to stop over there. And I know Shyam had some good discussions in mind. It'll be great to open up for questions, and I'm sure there'll be many. Let me stop here. Thanks.
Uh, Vidya, can I come in?
Yes, sir, please.
Yeah, thank you, Sham and Kavi for very crisp and lucid presentations. And I just wanted to tell you what's happening in India from what I know, so that this may not be, many people may not be aware, and also tell you that how we should go move forward. Uh, the Indian Council of Medical Research has set up a clinical case registry for COVID. I don't know if you people are aware of it. Are you, Sham?
No, I wasn't
Okay.
aware.
Let me tell you briefly about it, because when it was started, I was still in service at NIMHANS, and this is coordinated by ICMR. 100 hospitals have been included. They've been divided across the entire length and breadth of the country. And to collect data, they have used the institutes of national importance, like all the AIMS and NIMHANS. JIPMER was invited, and unfortunately, JIPMER declined to participate in it. And using these institutes of national importance, each one has been asked to identify 3 or 4 hospitals in their state. For example, NIMHANS has been asked to coordinate data collection from uh, large COVID hospitals or hospitals where COVID patients are being managed. And we have chosen 2 from the government sector, one at Gulbarga to represent North Karnataka, and one at Bowring Hospital in Bangalore, and St. John's Medical College, which is a private institution. So like this, and they have of course, a huge matrix to collect data, which covers most of what you showed and what Kavi showed in terms of symptom, signs, severity, outcomes, lab, and a whole lot of things. And as of today, as of last week, I know about close to 13,000 patients' data has been collected. They started initially retrospectively from the month of December, just after I retired. And it's going on now. And right now, I think because of the second surge, a lot of data is being collected. Now, this is being analyzed centrally, and the Institute of Research in Medical Statistics scientists at ICMR headquarters, IRMS, and the National Institute of Epidemiology are the people who are doing it. And each center, nodal center, is also encouraged to do locally their analysis. But all this is not acquired like way you're telling automatically from it's somebody who sits, there are people appointed who open the manual case file and enter it. And there is a person in our department at NIMHANS who actually does the data verification and cleaning. And so it's a manual process. So once the data is input into the database, and I don't know what kind of queries you can run and what program they're using. So I just wanted to tell you about this. And yes, what Kavi said, there are war rooms. There are war rooms set up in almost every state now. But most of these war rooms are, unlike the Pune war room, which Kavi was talking about, are used for routine data collection pertaining to testing, sorting out bed allocations, and trying to call people from the data center, from the war room, for contact tracing, tracking, epidemiological purposes, and basic data like percentage positivity, mortality, and things like that, social demographics, as you know. But none of the clinical uh, parameters, like the way they're doing in Pune, that kind of setup is not happening. So I thought I will just give you this briefing so that you people are aware, and maybe sometime it'll be worthwhile to talk to people in ICMR so that ACT and other kind of tools, if necessary, can be used. Of course, they will look at it with a lens, because India, the ICMR, the Health Ministry Screening Committee especially, is trained to look everything with suspicion, and probably they have their own reasons, and I'm not finding fault with them. that any data that goes out, they would not permit data to go out, and they are very, very protective of data and specimens, of course. And I think most countries do that. I don't find fault with that. And stop here, and I thought I should share this information.
Yeah, it'll be actually good to start talking if you have connects with ICMR. Really good to start talking. These things take many months and even years to go ahead. So it's good to start talking with them.
But
And
Kavi, I'll try to put you in touch with people, okay? And then both Sham and you, it'll be nice because you can definitely help out and probably learn some things also from what the way India is doing.
absolutely. I mean, I've come to know of like
It'll be
great
two. Yeah,
yeah, it'll be two great
I'll try to
innovation.
facilitate that with my
Yeah,
connections in ICMR. Oh,
yeah, that'll be very helpful. And just one thing I wanted to highlight, this ICMR project in which they're collecting data. Some of the hospitals in Pune are also involved. Just want to highlight the difference is that there they are manually collecting data, and what we are talking
exactly. That's
about
what I told you. It's all manual.
manual. And what we are doing here is, like others said, in this comment, that we are actually making infrastructure to automatically, collect the data, make machine learning models, and and make it available, to the. I mean, it is to help the local. It's the local people who are running it, and they will be the utilizers of it, right? So
And
we're talking.
I think like
Yeah.
both of you emphasize this point. This is a new way of doing things. With trying to bring in a culture, a platform that can be used for a variety of illnesses, be it communicable or non-communicable. I think that's uh, data is very, very important. Analyzing it and all interventions, I always believe all my life, right from my Jipmer days, is interventions should be data driven. It should not be on impressions and emotions. Over.
I think Dr. Narayan has raised his hand. Go
Yeah,
ahead, Dr. Narayan.
could I had a little different perspective? We have talked of clinical data. I'll talk of public health, which is probably the data is actually much, much larger. So I've been working with the public health data for a long time, and especially from the government sector. And again, I'll go with what Dr. Ravi said. They are very cagey about this data. They just do not want to share. When you want to get in, we have projects which are hanging. Yes, we'll share the data, but so it never comes through. So many projects, even a small state like Pondicherry, we have the problem. On a larger scale, the public health data flows from the Ministry of Health. There have been many projects which sort of computerize, but their attempts at computerization, one of the probably the oldest one is the Integrated Disease Surveillance Program, uh, the IDSP. But then those days, of course, the infrastructure was not available. So therefore, much of the data was only in the way of forms. So people would collect, and it was not individual level data. What Shyam is talking about and the others, Kavi is talking about individual level cases. But their given cases would get consolidated into numbers. So, and then you have lost lot of valuable information, which is especially for, even if it's not for research, for regular analysis, epidemiological analysis. Subsequently, this has gone on building up, many things have been added. But what happened, it was more of a top-down approach. And as very rightly pointed out by Kavi also, that they would look at the analyzed data. So they were designing, whatever was being designed was a top-down one, where it would first, the ministry wants this, so it is a consolidated report. It would flow down layer by layer and come down up to the probably the health center level. But it is one person who's the health worker who's sitting and collecting the data in registers, then transcribing them into a report, and then entering uh, into a computer at the peripheral level. And there was hardly any system of capturing the actual individual level data. And in public health, it becomes quite different because in clinical practice, it's a single level, it's a single episode. Each encounter with the patient is a single one. But in public health, it's multiple encounters. For example, if you are talking of an antenatal mother, she has at least 4 visits, and you have to monitor that, and then something happens. So this has been the greatest challenge. I've been looking at Karnataka, I've looked at Andhra Pradesh data. So when you get all the data, there's a lot of mismatch. In fact, my PhD candidate has had a lot of difficulty. Within the same form, there are total data mismatches because there's no way that you can look at this data. I've looked at Kerala dengue data. It is all numbers. So when you want to get into analysis of, for example, an epidemiological analysis, and it, it goes haywire. I mean, we are not able to get good quality data. So something which I don't know whether you'll be able to impress is that we have to get down, the data collection has to be done at the individual level. The analysis has to be done by the computer, not the other way around. But we have now the data collection manual, and then somebody is analyzing it, and it involves a huge amount of work for the staff, peripheral level people. Then it's entered into a computer, and after that somebody has got a dashboard, and the system developers are only showing a dashboard, and we are very happy with that. So I think this is a conceptually, we have to start now thinking of it in a, like Shyam showed, we have to start from the data source itself, and then once that's done, then the analysis becomes easy. Even data security can be built in. In fact, in Karnataka, they have collected the data, but they have a scheme. I believe there are 32 web pages collecting the same bit of information. Age, sex, 32 times you have to enter into different web pages because tuberculosis is different, maternal child health is different, and so on. I think these are some of the major issues when you look at data, especially large data, which we need to consider, and somebody has to put their act together. It beats me how it can be done. Thank you.
Yeah, and I just want to add the point that while we are actively collecting data, there's a lot of passive collection, right? For labs are this where healthcare is happening, tremendous huge amount of data is being collected passively. That is what we can leverage here. Even tying up with private labs. If you look at, I mean, labs are like the treasure trove. It's very objective. There can't be any vagueness over there. Definitely, there can be over testing, which happens all over the world. It's not unique for India. They can even be under testing. So it may be incomplete, it may be patchy, but we should see how much of passive data we can already take while putting the security and privacy measures in place. That is very important for public health. I mean, in the US, I mean, developing countries, you can do research for the sake of research. But I think for us, for the Indian setting and the low resource setting, it's very important to show the findings to be helpful for public health. Because if you can show that it works for public health, then there will be it can be sustained. So we need clinicians, computer scientists, and also public health experts in this conversation to take it forward. And that's what I see you echoing the same thought, that how it has to directly benefit public health. And IDS program would be great if we can help them out, give some help to them.
Uh, Subramania
One
Shivam is on the call, and he's also very much involved in informatics. So Shivam, if you could just say a few words, since you said you have to go for another meeting.
Thank you, Vidya, and great to meet all of you there. Shyam, as ever, you've become a geek, super geek now. Yeah, just on the aspect of data and looking at it, I just wanted to share the experience. I'm currently sort of helping the Ministry of Health in Saudi Arabia, and one of the things was to actually run their COVID response team. What we relied there on was actually the mobile-based approach. See, we talk of computers, we talk of all those things to collect data, but the greatest power, particularly when it comes to pandemics and such thing, is the mobile phone. And so we relied on app-based data capture directly from the public as well as from healthcare providers. We had quite a few different types of apps, both for screening as well as vaccines. And we had a what we call as a national command center. And the national command center had the ability to actually then pull all this data, not only from the mobile platform, but also from the various HIS systems, particularly from the primary care systems. Luckily, 75% of the primary care systems there have an HIS system. But what I realized there is the power of the mobile, and mobile is the way to go, particularly in many countries, particularly the African, I think the Asian countries. And we should always explore the power of the M-health versus just E-health, I feel. The other thing we did was actually to use the mobile phone actually as a COVID monitoring tool. And we developed an AI-based application to monitor patients directly from the home. This is based on computer vision and a concept called as photoplethysmography. Non-contact remote photoplethysmography, and we were able to actually get to an accuracy level of about 95 to 98% for oxygen saturation monitoring using just the mobile phone as the device with no other secondary device. And it's now for actually rapid FDA approval as well as CE approval. It has gone through the Canadian approval process, approved in South Africa. So the key thing I wanted to actually bring to the discussion and the table and the thinking is don't limit the power of the mobile phone as an IT device. And using the mobile phone in scale is actually a very, very successful, I would say, tool, because see, one of the challenges, like what Dr. Narayan was saying, was engagement and adoption is a big problem when you use IT platforms. When you use mobile phone and mobile-based apps, you all know how easy it is, how rapidly we adopt. So a key success factor in technology-based and data-based sort of programs is engagement and adoption. So you have to think at how easy it is also to engage and adopt a larger group of people. So that's sort of the comments I just wanted to add to the discussion. But great job, Vidya, and thanks for putting this together.
Kavi or Shyam, would you like to respond to that?
Sure. So, so I think one of the things I would like to just state is that the I2B2 system, this is completely open source. It's been around now for like 20 plus years. And it's a way for essentially converting EHR data as well as other kinds of patient data, which might be captured in other ways, including mHealth, to be put into a format which is amenable for large-scale research. And so this can be done at an institutional level because the technology is available, the expertise is available, because the I2B2 is set up as a foundation, and there are groups constantly talking to each other and helping each other out in terms of setting this technology up. And more cloud service providers like Amazon are coming in. And so setting this up is even easier in terms of the software. And then it just comes down to like, what kind of data, what kind of processes do you need to translate the data into the standard terminologies and coding systems and other things. And it can be anything. You can come up with your own like terminology systems to be put into this I2B2. And I think you can look at it as a long-term solution for taking data, which is patient data, which is collected for other reasons, but kind of making it amenable for research and epidemiological purposes. And you don't have to depend on a central federal level to do this. You just have to kind of incorporate it with the institutional's research mission and put it in there. And then it can be leveraged by not only for clinical research, but you can also leverage it for epidemiological research. And eventually you can start leveraging it for monitoring like pandemics at the public health level. So I think that's one thing to consider in ways of like starting some of the kind of the basic work in India, because IT and IT expertise is very freely available in India, and almost every technology company has got at least one big office in India. And so getting these resources is pretty actually simple. So it just comes down to having a group in the institution which says, okay, let's do this long term. And we just do it for ourselves. And eventually it will be useful at the state level and national level, and even at the international level. Because as Dr. Narayan was saying, the top-down approach which public health takes, which is present in many countries, is very slow. And to some extent, even the CDC in the United States does that they have people reporting on, say, certain communicable diseases from the hospitals. The hospitals themselves don't know what the prevalence of the disease is, because it goes into the CDC, they take a month to report it out, and then you say, oh, okay, we are a hotspot, or things like that. But if you have something like I2B2 set up, then you can kind of do your own little surveillance at your local institutions and not have to depend on the public health at the central state level to feed the data back to you. So if you want to know things like, okay, how many COVID patients there are, or how many people tested positive on a day-to-day basis, you can essentially just do it all yourself at the institutional level. And so I think one of the things I think long-term with this would be is to leverage this I2B2 ecosystem for all kinds of disease surveillance, disease projects, and even for just research projects where you're generating all kinds of hypotheses. Eventually, of course, if you find something interesting that this drug seems to work in COVID, you'll have to do more full-fledged clinical trial kind of research. But at least the EHR data will give you some idea that this might work out. And since the data is kind of available, you can just put in the work to put it in a form that it's usable. And the advantage of the I2B2 is that anyone who establishes I2B2, they're forced to conform to the same way of putting the data in. So it becomes easy to talk across I2B2s. And that's the biggest advantage it does, is it standardizes the way you collect the data and put it in place. Compared to like if you let people do their own thing, then different organizations want to collect the same data, but they code it up differently. So you have, even in, say, public health, tuberculosis, you collect data in a slightly different way. Dengue, you collect data in a slightly different way. And you're not able to like use machines to essentially talk across all these data. So you want to collect the data in one format, in one place, and then use it for anything you want, any kind of disease, any kind of public health problem, rather than you do data collection specifically for each problem and each disease. That's just a lot of work being done over and over again. And then the second layer, which we are starting to do, is how do we take data which comes in and very quickly translate it into something that is actionable, either at the public health level or at the clinical level. So these would be where the AI comes in, which is you build your AI and machine learning models, which can be pretty much be built almost on a weekly basis as new data flows in, which might be useful to, say, predict severity of COVID, for example. So that's like the second layer. But for AI to work, typically you need just large amounts of data, which is feedable into these AI machines or the AI algorithms. So the hard work actually goes into doing this data collection and standardizing it. And then the AI can run on top of it. But once you have it, yeah, like in a standard format like I2B2, it becomes easy to do distributed analysis, for example. So the advantage of the I2B2 system is that you can still preserve the data locally. You don't want the data to go out. But you can now have, say, code which is written for some statistical analysis, which might be written in one place, like in Boston. And they might say, okay, we just want to know what the risks, what the odds ratio are of, say, getting thromboembolism because of COVID. And they write whatever the software that you need, which computes all these odds ratios and risk ratios. And then you can just run it on any I2B2 after that. And so you have analysis now, which is local to your institution, which you're able to get by running the software. And you can accumulate all these summary results across all the institutions and say, this is how it looks. And at that point, usually no one is averse to sharing that summary level data, just knowing like, what's the risk of developing something at this institution and that institution and that institution. That kind of data is usually okay with everybody to share. What you really don't want is the individual level data going out of the institution.
Satish, would you like to say something? Satish Balan?
Yeah. So good evening to all. Shyam, nice to see you and nice to hear your wonderful talk again. So I just wanted to say that there are unique problems in India for data collection. One is the nature of the data that we have. See, for instance, if you have an electronic health record, whether it's a government or a private sector, it's very difficult to collect data from that. Our hospital, I'm working in a corporate hospital, and here we have a EMR, which is pretty good. But the other day, I wanted to collect the data on acute kidney injury in pregnancy over the last 10 years. And they gave me the list of all the acute kidney injuries. So I had to delete the males. Then I had to select all the females and see how many of them are pregnant. So it took me about 1 week to go through that data alone. I could not get that single data. And imagine that these are all inpatients. So acute kidney inpatient never treated as outpatient. So that inpatient data I was not able to collect despite reasonably good EMR. One of my colleagues in the government sector, he was working in the Indian Institute of Diabetes, which had an EMR since the last 20 years. So they have more than 10,000 patients and they had an enormous data. So he wanted to collect the data and see how many of them developed nephropathy over time, retinopathy over time. And he could not do anything with the data. A lot of data available. Then he called some computer engineers from IIT Chennai and they said that you cannot do anything because the data is so haphazard. You cannot do anything with the data. It's just data which is lying there. So unless you manually pick up each bit of data and then arrange it, it's going to be an enormous process. So, and third point is that none of this data is connected. Say if you have a Trivandrum Medical College or a Calicut Medical College, they have data which is stored in the backend server. And this is data unique to that point, one EHR which is created there. So it's almost impossible to lift the data from there. It's much more easier in the old days when you just go through the files. They had a medical records department which should keep a note of all the ICD codes and you could see, you just pick up the files. It was easier in those days actually. Now it's even more difficult to do that. So unless you have a common EHR system in the country, which will do the data properly, it's very difficult to even conduct a study. Just to collect data on IgA nephropathy, I finally had to give up because it was just impossible to collect data that is there. The final point is whether the data is reliable. For instance, the COVID data that is absolutely accurate. For instance, the Kerala government declared that, say, 60 people have died on one particular day. On that day, there were 20 bodies in the Taikad, in the Trivandrum crematorium, which were buried under COVID, which were cremated under COVID protocol. So you can remember that is 20 bodies in Trivandrum alone, and those are only Hindu bodies because only Hindu bodies are cremated in the crematorium. So you can imagine the number of deaths which have occurred in the whole day. So this data is not reliable, and the government is not releasing proper data. So there must be some data collection somewhere which is giving you data of all these COVID patients, but that is not being released by government. So that's a problem in times like this when the governments are also competing with each other to declare lower mortality than the other. So it's unfortunate, but we don't have true data. That is one of the problems. Whether the data is not collated in the proper form for collection, it's like data which is collated is also not really up to the mark.
I'd like to add to Satish's question because it's pretty much on the same lines. Can I go ahead?
Please do.
Sure.
All right. Thank you so much. So I'm Adarsh. My question was on the same line as Satish. From a dissonance between the media and the authorities, it looks like with the amount of technology prowess that India has, the dissonance and the fights would soon shift to analysts versus the authorities and versus the government and stuff, right? Which means that data collection, I think a couple of people here did mention it as well. Collecting data, putting it out is something that authorities might want to avoid. Might be fair, might be unfair. Not getting into that here. So I would like to just pause here and draw a parallel. For example, the way Apple deals with privacy, Apple collects the data of millions of people through Apple Watch, but the identity is anonymized, so the the consumer's privacy concerns are answered. The data set size is also reasonably anonymized, so you wouldn't know how many people have something like this, and stuff like that. So uh, while we could discuss and argue the demerits and merits of it, is there a way through technology that we can solve? Because the populism is taking over the world, and data would be a problem. Is there a way to balance this out using technology, where the government and the authorities do get what they want, at the same time doctors and clinicians do get rich access to insights? Is there a way that technology can help solve this? Is one of my questions. Yeah.
Kavi,
So
would you
I
like to take that
yeah
question?
yeah. So I2B2 does exactly that. It anonymizes the patient data and doesn't allow you to go below a certain size of the population while retrieving a feature, right? That's why it has thrived so much. It gives the power. Yeah. So that's privacy first. So that problem is solved in I2B2 about the protection of privacy. Now, about balancing the top down to the bottom up approach, I think even what we're proposing here is like if you go for hospital data, it is just 5%. 95% of care in the low resource setting happens outside of bigger hospitals, right? So even if we do this, imagine if all the major hospitals in India have the I2B2 system, it is still 5% of but it's still a good sample. And you can draw a lot of inferences from here and do reasonable things. We know that the EHR data is noisy, and the same we even in to Shivam's point that that he had to curate and it was not reliable what he did for kidney injury. We have the same issues here, even in the rest of the world where EHRs are implemented, because there is a dissonance between uh, data being recorded as part of routine care and what you require later on for analysis. So there is some cleaning required, and so I2B2 has got these components which help a lot. One part is harmonizing, converting your local data model to a standard data model. And so some of these technological challenges are solved, but the question what is here is that who is going to do it? Should we wait for the government to do it? What can we do at our side? And we can do it locally. Let's not worry about helping the government. Can we do it at a hospital level? Can we already have data? Can we put our expertise together and use the collaboration that we have to draw insights? And we will learn. Maybe we will find that our data is bad, but we'll know where it is bad and where to improve on. But I feel very confident that at least for labs, labs appear to be structured. If you ignore the health symptom data, so I also happen to talk to many government experts on this, and I always tell them that leave the clinicians alone. There is a huge volume of and Dr. Ashok also made the same point, that there's a huge volume in India of patients, and you can't expect the doctors to feed data, right? And we are saying, let's not do that. Let's just tap labs and tap medications and whatever other ancillary data is there for admissions, and let's see how far we can get. And I'm sure we can, based on the research, even what Shyam presented and represented, lab data alone can help you do a lot of epidemiology and do practical things with it. In fact, there's a chance for India to obviate some of the decisions made in the West, in which clinicians have been made to enter data and they are not happy with it now, and there is always a tension on that aspect. uh, Sham, you want to add something to Sham, and Sean, do you want to add something more to that?
Yeah,
I have a
so
question just before Shyam answers. Yes, question to Shyam.
Yeah.
Or Kavi. It appears that the ICD classification is paramount through this. Is it correct?
no, it's not necessary. You can use anything there. So we just are using things which are commonly used in the US. So the US, for various purposes, including billing, uses ICD to be put into the EHRs and so on and so forth. And that's why we have it. But you can put any terminology into the I2B2.
Oh, okay.
So
No,
there's the
the
Indian
coding is probably not as important, because I doubt whether all hospitals would have. JIPMA has, but JIPMA had a good coding, but I think the volumes are just too much. I do not know what is the current status, how well it's done. Other institutions, how well they code because that's a post, what should I say, treatment or post event after the patient has left with the proper coding.
Yeah.
I don't know how well it is done. If not, that's not important, then probably there's a lot of potential in this.
Yeah, that's probably.
I would also like to add that there's a group in IIT Mumbai who's working with data. If you're, maybe I can share that information. I'm with that group. They are doing training in several aspects, especially geographical information systems. And they are also into the same game of developing software or dashboards and collecting data. So they have done a lot of work on nutrition. If you're
it'll be
interested, I
awesome.
can link up with them.
It'll be awesome to connect with them.
Yes.
I'm sure there are some groups in IIT working with the Mumbai, municipal corporation directly.
Yes.
So there might be some other links we can definitely. It'll be great to connect with them, and we do require to engage the computer, brain power, in the IITs, and we want to connect them more and more to our hospitals, right? And we want to catalyze that collaboration.
This particular group is working with geographical information systems.
Yep, sure.
Dr. Ravi, would you like to say something based on all the discussion that's been going on in the past few minutes?
Yeah. I just want to. I mean, it's very nice to hear all these discussions. The biggest challenge, I think, is standardized data collection, and I think, as Shivam mentioned, and others have mentioned, we have to get into the culture of using a smartphone. That's the most accessible device that is there. And I did a huge CDC funded project in Uttar Pradesh, Bengal, and Assam on encephalitis, where actually we used the smartphone in 24 district hospitals to collect information on encephalitis patients admitted. The complete works right from social demographics to lab data to clinical manifestations and presentations. And it was open source Norwegian HISP platform that we used. And we, of course, at the end of the project, handed it over to the government. I don't know if they're using it or not. So the point I want to make is that culture has to come in. Now people have started using tablets and smartphones. A lot of hospitals during COVID time, because being in people.
I lost him.
You are muted, yeah.
Okay, sorry for the interruption. So a lot of hospitals and resident doctors are now getting used to using the smartphone for collection of data. I know in Bangalore Medical College, it's a large COVID hospital. In John's, where my son works as an emergency medical physician, as an assistant professor, they've all now switched over to using app-based collection of data. But uniformity across hospitals is not happening. The electronic records, everybody has tied up with either a local vendor, a local or they don't use uniform platforms. I think that's a huge challenge to get uniformity across hospitals.
I think
like Shyam and Ravi both said, you need I2B2 and you need a proper software to connect both of them. So that, I think, is the challenge. But somewhere these discussions have to start, and somewhere this has to happen. I hope things will happen.
Yeah. So one thing is having standardization, whether it's in medical care or even software, is never achievable across the world or even across a country. So the US also has the same problem. You have all kinds of EHRs. Like my institution with 40 hospitals has got somewhere around 70 EHR systems running all over the place. And each EHR system has got its own peculiarities. Plus, the same data, like say hemoglobin lab, in one central lab in the hospital system will attach one code. And then the other central lab attaches a different code. So that is ubiquitous even in the United States. And so what the I2B2 forces you to do is, it says this is what hemoglobin should be called. And so whoever is kind of cleaning the data and moving it into the I2B2 system is forced to do that mapping at that point. And so that effort has to go in, but you have to do it only one time. So once you've done it, then that data is now attached with some kind of a standard terminology like a Loin code for hemoglobin. And once you've done it once, then you're good to go after that for any kind of research. Because now you know that every I2B2, no matter where it is, as long as they're using that particular terminology, they're all forced to translate the data to that. And that's where the power comes from, comes in, that you're forced to do that translation, and you can't expect the hospital systems and the clinicians to standardize the way they enter the data. You have to do this at the back end. And sometimes this can be done automatically and through machine learning ways of doing things. And the data is always going to be noisy because this data was not collected for research. The power comes from the volumes. So a place like India, the volumes are so big that you can actually, based on some of the more advanced statistical methods, be very confident that even though your data is very noisy, that you can make a particular inference or a conclusion. So that's where Google gets all its power from. Almost all the data that Google has is very, very noisy, but yet they can, with very high precision, say certain things about you as a person, for example, or target certain goods at you. But nobody is doing very clean data entry for Google. They're just scraping data from all over the place, which is being collected for various reasons. So some of the advanced statistical methods are able to handle all the kinds of problems you see with EHR data. Your missingness problem, the way the data is collected in one place might be different from in another place, and that causes statistical issues. It's biased in various ways. All that, there are like new methods which are being developed in the statistical machine learning world to deal with that. And most of them kind of depend on the fact that you have large amounts of data. That's where the power is coming from. So the power that you get with standard research is that you deal with a small cohort, but you do very, very good data collection. Here we are turning it on the head. We are basically saying we can never be sure how good the data collection is for any of the patients we have, but then we have millions of this. And the data collection is not totally random. And the values are not totally random. Yes, there is some noise, there's some errors, there's mistake, but it's not totally random. So once you have massive volumes, then you do see sometimes you can get to conclusions which are as good as when you take a small cohort where the data has been very cleanly collected. And of course, there are situations where large noisy data cannot help you. And there are situations where small cohorts, very carefully collected, also cannot help you. And so you need both. You still need to do the standard kinds of clinical research where studies, you spend a lot of money to collect data very carefully. But this is a complementary way of doing things. This is more quick and dirty. And sometimes, because the data volume is very big, you can pretty much with very high confidence say, this is what is going on.
Adarsh, you had a follow-up question.
All right. Thank you so much, Vidya. Dr. Shyam and Kavi, thank you so much for explanations. Lovely the way you broke it down as such. I'm going to ask a question, but I'm not sure how relevant it is here. So you can choose not to answer it, and so the others' question get answered as well. On the same point I had earlier, and this question is directed to Shyam, is that there is a constant push and pull between, I mean, for people who are looking to make a career out here and people who want to invest in this, spend time on this, etc. One of their questions would be, is there a future in this, right? Which means that is public health analytics always going to be on a push and pull with the government, etc. Right? So my question to Shyam was, is there a technological way to solve this where the government gets what they want, at the same time we are able to arm researchers with what they want? I'd like to draw a parallel to this. Back in the a 20-second story, back in the 1950s, when the US was moving out of war and starting to spend on infrastructure, there was, people wanted to spend on war, and there's another set of people who wanted to spend on infrastructure. Eisenhower laid really large roads, saying that these roads are for cars, but if war comes, you can also land flights on it, right? So he was able to, shut down both people with just one thing as such, and that's a great solution, right? You could get what you want. Is there a technological version of that where you could satisfy both fronts? That's the question. You can choose to answer it or not. I'm sure others might have other questions as well. Thank you.
Maybe Sean can take it, whatever. If not Shyam.
So I think if you have data already kind of formatted and curated for local research, a lot of that would be feedable to what the public health needs. And in fact, I can give you an example. So the traditional public health is very top down, right? So you have a public health agency, which is a national agency, and they basically say there are certain diseases we are interested in, and fill out these forms whenever you see this disease and push that forms up to the central agency, and then they do all the data collection and analytics. That's kind of a very slow way of doing things in fast-moving pandemics. New technologies have been developed. So one example here in the US was after 9/11, there was a worry about bioattacks. And so there was a lot of money put into research to do biosurveillance, which is very different from the standard kind of public health surveillance, which is the standard public health surveillance is pretty accurate, but very slow. And so it's the same concept of small amount of highly curated data where you spend a lot of energy versus a large amount of very noisy data. So in this example, in this biosurveillance, some of the research which was done here in Pittsburgh, what basically they started doing was we got data from retailers who sell thermometers and painkillers, over-the-counter medications, which are for pain, which are for fever reducers, which are for cough, and thermometers from about 90% of the retailers across the country. And those were coming in every 24 hours. And you could look at those spikes. So you could look at like suddenly there's a whole bunch of thermometers being sold and make a pretty educated guess that there's a lot of fever-like thing going on across the country. And it's noisy, but because you're getting 90% of all the sales coming through, it's a very strong signal. And it was actually used to predict like when the flu season is starting up, for example. So that's an example where you're leveraging not even clinical data, but you're leveraging like data which is being produced in the retail sector for a completely different reason and using it for biosurveillance. So, so I think it's basically, I think one of the ways to look at this problem is there needs to be a lot of crosstalk across the silos that we have. And in India, especially, these silos are still pretty strong. So you have kind of the medical community silos, you have hospitals and medical schools, which only do medicine. And then you have the kind of the engineering and the computer science folks who are in a different place and who only do that. And then you have the epidemiologists and kind of public health folks who are sitting in a different place and only do that. So these people have to start talking to each other more and collaborate and do maybe even collaborative projects. And then you can get into these kind of new ways of getting data and doing it for public health as well as for other issues. So, so even the CDC in the United States, like for example, it's a very top-down organization, and it suffers the same problems that they'll make decisions which turns out to be bad in the longer run, and sometimes they'll keep going back and forth across the decisions. So the CDC has an informatics division, which basically seems to cycle every 5 or 6 years that they disband it and say it's useless, and then they come back and re-put it back in. And so, so there are times where the CDC has got really, really good technological solutions. Data is flowing in for the things that they want. And then there are other years, like now, during the COVID era, they basically can't even get to the COVID data that they want because all the technological systems, essentially the unit which does that informatics has been disbanded about 3-4 years ago. And so even here, we cycle through that issue. And so the same thing probably happens in India, that the public health agency probably cycles depending on the decisions the leadership takes. But at least one thing is, if the local institutions basically say, let's start somewhere, like say lab data, which is reasonably structured and easy to get, and let's put only that into the I2B2, and let's use it for everything. Use it for clinical care, use it for research, use it for supplying data to the public health if they want. Then I think you get the power. And then the public health folks will start looking in and they'll say, oh, okay, we will rely on I2B2 to get to the data that we want if a lot of you have implemented it. But I think, yeah, it's kind of like, there has to be, I guess, more talking and collaboration across all kinds of people. And I think that's happening more and more now, because one of the silver linings of COVID is that it forced people to go online, use Zoom and things like that, where it's far easier to get people. Like, we wouldn't be able to do this if it wasn't for COVID. We actually wouldn't be doing this, talking across countries, if it was for COVID. So that's the silver lining of COVID.
Maybe I can add a similar sort of anecdote here. You know, one of the challenges we had was to plan for the health needs assessment of the whole of the country for Saudi Arabia, to understand that the burden of disease. Now, people always think burden of disease, go to a ICD-10 coded system and try to find how many people were diagnosed with diabetes and add this code and that code. But the approach we took was actually multi-pronged, and we had HIS system data, we had information from, say, just e-prescribing data, we had information from schools on school health, just number of times a child went off sick. We had information from retail. So we actually created an interoperability sort of platform where we pulled in information, not data. We pulled in information from different sources. And then there is inferential engines that you can run nowadays. You don't need to necessarily say that, A plus B plus C is equal to D. You can always say A plus B plus C is somewhere equal to D. And that's good enough in many situations. And for particularly planning purposes, for doing a clinical decision support for an individual patient, that's a different thing. The precision of inference and the precision of correctness of data is different. That is, if you want to take a decision on whether to give a drug or not to give a drug for a patient who is having XYZ, vitals, that's different. Whereas if you have to decide whether I have to build 3 hospitals or 25 hospitals in Karnataka, and whether these 3 hospitals have to be placed in north, south, and east, or whether they should be central. Now that decision doesn't need that level of precision. So I think we have to also understand the use of the data and be cognizant of what approach you take. The other big thing which is happening, and we're doing a lot of work on that in the biopharma industry, is use of real world evidence, as we call it. That is for even clinical trials now. The days of randomized clinical trials with structured data collection, which is so rigid and all that, is soon going to go past by just taking any observed information from clinical systems and using those real world evidence to actually pull insights, particularly in drug effectiveness, we're all talking about, is ivermectin good, or this drug good, or that drug good. And quite a lot of these inferences can also come through what we call as real world evidence. And that's a very big field in both data and as well as machine learning and all that. Another area that is really becoming big is use of NLP. NLP is sort of actually a mix between machine learning and inference and logic and all of that put together. But what it essentially says is, for Satish's problem, If I always have to go and look for a coded data of acute kidney injury, then that's going to be difficult. But if I went and looked for creatinine level and then inferred from that that possibly this was kidney injury, if I went and looked for dialysis and then say all those who had dialysis possibly had kidney injury, hopefully, so you bring in 10, 15, 20 different proxies for the particular information you want. And therefore, you're able to actually come to that same conclusion that instead of actually sitting with a million patient and saying, I don't know who's having a kidney injury, you might use 20 proxies to what is kidney injury and derive that. So there are many techniques happening there. It's a phenomenal world out there. And similarly, there are a lot of data platforms which are coming now, which are taking away even the burden of structured data collection. They're saying you capture it as diabetes, another person can capture it as DM, another person can capture it as diabetes insipidus or diabetes mellitus. But here we will use our knowledge of healthcare and the ability to bring all these three and call it as diabetes type 2, for example. So there are data models which act on that principles of interoperability also. So there are tons of solutions which are actually going to solve these in the future. Thank you.
Yeah, so Shivam, so what you're talking about, we call that the computable phenotype. So that what it really means is essentially you can take all kinds of data specifically coded for that particular condition, or text data, or even retail data, or even image data, and basically say that with very high fidelity and very high confidence, we can say this is diabetes, and do machine learning to do that. So that's becoming very prevalent. So that does help with the fact that we'll always live in a world which has got nicely, cleanly coded data, but also a lot of free text, but also maybe a lot of audio conversations, a lot of images. So slowly we can actually handle all these various kinds of data and have it basically inform what we are interested in. If you're interested in knowing whether this person has diabetes, technology is now available. We can throw everything at it, and it will tell you that, okay, we can combine, like combining free text data and structured data now can be done with single machine learning paradigms. You really don't need to treat them differently anymore. So you don't really even need to do like this special thing called NLP on text data anymore. You can actually throw the text data in as words, all the structured data in like ICT codes and all that stuff, everything together, and deep learning will actually handle them all at this point. And it can handle images too as pixels. So, so the need to have the data really formatted well and cleaned up really well is kind of decreasing as time goes on.
So Amit, one of the, when Shyam was showing the examples of how the act works, Mayo Clinic came up with a maximum number of data most of the time during the searches. So you have something to say about what we've been discussing for so long?
No, I've been learning a lot more than I can say, and of course, this has been a fantastic discussion. I had to go in and out to see a patient. Where I am using AI is something which Shyam probably knows is Mayo Clinic has analyzed all these EKGs of patients, millions of EKGs. So I'm able to see an EKG of a patient and put it through that format, the AI format, and it gives me a couple of variables right now, what's the patient's chance of having an atrial fibrillation, what's his real age versus EKG age, which shows his level of conditioning, what's his risk of developing aortic stenosis in the future, cardiac amyloid, and then also HOCM, and yet one more thing. So I use it carefully. It's not a clean data, but I have seen when I use it where there are individuals who are 75 and 80, they are exercising, they're in tremendous health. And when I see that their EKG age is 61, when their real age is 78, I show that to congratulate them on what they're doing. So they're doing this kind of scripting for numerous diseases. But what is happening here is that's an individual level work of hospitals like Mayo and others doing the work. Our doctors here are utilizing India. I have an EP person from Vellore here who says, Shyam Visweswaran. He says, Amit, you cannot imagine the engineers we have in India who can figure out from the EP, the sound signals, and produce it at such a micro and a fantastic level, which is not possible in US. So he travels frequently to India and get this done. So as everybody is saying, the knowledge and the expertise is there. In any EP group or any AI group here, we have Indian computer scientists and everybody working in it. So the hand is there everywhere. The real challenge is separating what is happening here for a public health hazard during a pandemic from hospital-required data, like somebody is doing a work on IgA nephropathy or AKI or something. These are two different things. US has got the US KPD, where they have a huge database in Minneapolis where they capture this data, but at an individual level, maybe each of us can do it to get the specific hospital level data. But until unless we have this clean understanding of why are we doing it, is it going to politically unstable us? Those things become difficult for public health. So, but in any way, what this discussion has happened, as Shyam and others have mentioned, is no longer are we going to insulate ourselves. The scope for big data is here. Henceforth, whatever we do has to be bounced by what system are you using, how are you getting data. There are enough knowledgeable people who have gathered, enough people frustrated who are gathered to get this done. And so we will probably have this huge force where by 2030, we should have this AI playing very central role in every single area. So I'm just a follower. I'm seeing it, learning it. The science excites me. The way of looking at the data excites me. I do agree, and I got really fascinated by all the comments which came up, which is really fascinating. This is also a side comment is in the Facebook, in JIPMER Facebook, a very senior guy was lamenting about the role of JIPMER and what we are doing, and the younger faculty is not doing much. They're completely oblivious of the kind of discussion you're having in marvelous medicine by our JIPMER faculty all over the world. And the brilliance of them is not being demonstrated. And I'm trying to bring them up and attend your meeting to see, hey, these people who are doing this research, they don't have time to go to your Facebook and to tell or beat their chest and say they're such and such. Why don't you listen to them and get to enjoy and learn from them? And this is exactly a conference like this is so vital in, it's a very high level conference. In fact, it's much better than what I hear in Mayo, because I only hear one grand round, and here I'm having experts from different parts of the world giving them cumulative expertise. So anyway, this is a great conversation to have, and I can't thank you enough, Vidya, to bring this kind of experts week in, week out. I'm very fortunate one of my patients didn't show up, so I could kind of get to attend part of the conversation which is happening. The net point is we are all frustrated, but we need cool people like Shyam to work us through the frustration and not lose it, not get into the politics of it, clean the data up, use the big data. It's for the rest of us to keep pounding, not give up, not say that we have a problem where the problem is. We have to find a solution and do it with expertise. So I think this generation is meant to prod along and work hard and get to the new vista of medicine. And engineers can't be away from us. They have to be part of us. The ego part has to go too. It can't be that I did medical school here and this and that. It all has to work in this science together. There's lots for everybody, and enough food and enough rewards for everybody to go around. Each of us can't chew it all. So it has to be, everybody has to step in.
Nalla, would you like to say something? Just unmute yourself, Nalla. Nalla, you need to unmute yourself.
Yeah, thanks. Thanks, Vidya. Sorry. Nice to be on the show again. I just wanted to, and Shyam, he was the data man of our batch. So obviously he's full of only datas. Two suggestions that I wanted to share with all of you. One is that COVID is such a disease which is always changing day by day. So in such a situation, collecting data and sending up data can be sometimes good and sometimes be very alarming. What I came to know like yesterday from the Indian Medical Association, when the second wave hit India, more than 300 doctors died and only 3% of the people were vaccinated. I don't know if it's true or not, but this is what was told. Now, just to share on that, so data can be quite good as well as it can be bad. But what I want to share on the other thing was what we saw last year in UAE. It's a 10 million population. We follow with what my brother was telling. It's purely a mobile app application. All of us are being tagged down and completely, it's so strict. Vaccination, date, everything, COVID test, every data, everything is entered in my mobile. So everybody, the command center can access it completely. Now, what I observed, apart from data, like Shyam said, data is good for all of us to see and learn, but we can also learn from our own experience. In my own hospital or in our own place, compared to last year to this year, all the doctors and frontline workers who were vaccinated have never developed a COVID in our scenario. So I was quite shocked. So that was a data which said vaccination helped us. One is, even if you get a COVID, they never went into an hospitalization or ICU necessity. So the vaccination definitely was something that was not there last year. And this year, the entire UAE is almost 80% vaccinated now. So we are more confident. And as an anesthetist, I again sharing it more to you because last year, my approach to the patients were completely different. And now we are more happier because all of them are vaccinated. So vaccination did show a lot of change. And even if you get a COVID, you're not going to be so sick. So such sort of data, which gives good information, should be more useful for the public. So I was quite shocked with what was in the Indian scenario. And I only wish all of you as healthcare workers, please go ahead and take the vaccine. Just because there was a data about vaccine which said few people died, few people developed blood clots, few people developed palsy. So that was quite alarming. And maybe somebody can restrict yourself from going ahead with what you want to do. So data is good, but data in such sort of COVID and things can be dangerous. Data in a chronic disease is fantastic. Diabetes, hypertension, cardiac failure is phenomenal. You can have a 20, 100-year follow-up of everything. But in a pandemic like this, which is changing every day, every month, data can be, I don't know how Shyam must be changing his data every day then with what scenario comes up. But it's always good to know from the data that at least when you have a patient, what are we looking at and what can be the choice of treatment and things like that. But data should also be quite careful and if it should help the people, not only alarm the thing. And I hope all of you get vaccinated and stay safe. Thanks.
So I just had a question, I think probably, I don't know how much more time do we have. Wondering from this discussion, that group that we have, can we have a few sites, can we do this in Chennai? What would be the next steps for doing it? Which hospitals, which institutions, and can we set up follow-up calls and, any thoughts on that?
I think I will sort of keep in touch with you and Shyam regarding that. I should be able to put you in touch with few places where it will be actually possible, and at least the amount of the volume of data should be significant enough to make a difference. So Suvan, did you want to say something?
No, not really, not really. For me, it's a little bit over the top. So, yeah, but Shyam's a good friend. And in fact, we got, I think, 4 classmates over here. So it's a kind of a batch meeting for us. So, but yes, I am enlightened. And of course, I do get a lot of inputs from Shyam in our batch groups and all. Just to, since it came up contextually, countering what Nalla said. Now, the problem in India was that it was voluntary and not mandatory, the vaccination of healthcare workers. And that was one problem. Then the system of mm, handing out the vaccinations was not very accurate. Though you could walk into a PHC and have it done, but then there were a lot of misses and slips and gaps in there. But we've had a lot of and then there was a little bit of propaganda against the vaccine from some scientific lobbies, established scientific lobbies who held fairly good credentials. So that was one issue. And unfortunately, we've had certain vaccinated people also, healthcare workers also dying. That's another concern, with comorbidities, without comorbidities as well. So a lot of gray areas over there. But yes, fortunately, I think most of us over here are vaccinated.
Yeah. So Radhakrishna, I think we are kind of nearing the end. You want to say anything?
Yeah, listening to Shyam is always encouraging, and it's a good discussion. Kavi has gotten some very good points, but again, it pains me no end to say that paperless hospitals in India are far and few, and a lot of, I don't know how EHRs work in government hospitals, especially state government level, but corporate sector, a lot of them are very terrible shape, as Dr. Ravi is mentioning earlier. Some local vendors try sell some small softwares, and that's how it's used. And having said that, especially data for COVID is something very, very scary, because one is we have patients in trade centers, we have patients in exhibition halls, we have patients in five-star hotels, we have patients in Kalyana Mandapams where there are no computers, there's no any data. I really don't know. Not just that, even I see in the corporate sector, the nurses, the doctors are all in moon suits, and they can't hold a pen or write anything on a paper or type on a computer. I don't know what data, anything, but it matter. Even I want to find out about a certain patient, I have no idea, because it's such a chaos. The only software which works very strongly, and actually many others pointed to, is billing software. You can say how many patients paid how much money is pending against how many patients had 4 remdesivir or 5 remdesivir. I think from there you can trace, but again, that's a very private data which is not sort of given. And this is all what is when Kavi is asking that which hospitals can participate, I really don't know which hospitals can participate, because a big government hospital, they don't have a count of how many are admitted, how many are dying, how many are on ventilator, and so on.
So you did.
Who is entering data where, into which computer? I really don't know.
So you did mention that there is billing software. At least billing software is there about some drug restriction
the billing
given.
software.
No, we don't want the amount. All we want is, in the hospital, if the hospital can abstract out that, okay, this drug was given, or this procedure was done, this admission was done, the patient was admitted for so many days. Yeah. Those are some of the variables which should come.
They'll have this patient had 5 remdesivir, but the patient's D-dimer, CRP, you'll have no idea.
But the labs.
I beg to differ, RK, because the lab values are all tracked and they are all in electronic form. Even if the health records, that is, I still, in my hospital, we don't have a electronic health record, so I write my notes. But the lab investigations and the pharmacy and everything else is there. You can pull out the data. And also for every patient's report, a trend is also reported. Like if I ask for a creatinine today, with the same UHID, if in the past so many years, how many ever times a patient had creatinine done, almost all of that will come. So if I suddenly, this admission, I suddenly find a creatinine of 1.9, whereas previous or 2 or 3, whereas all the previous were 0.6, then for Satish's sake, I can think, okay, that's AKI. Because the last time patient had a normal.
That all sounds interesting. We can start from there, Vidya, and I think this is quite an encouraging thing. For what I can hear is we have to make some beginning. We know where we are, and we should try put things together and move forward. And I think administrators should listen to a conversation like this and see how bad we are in collating data or collecting data. I think at least it will come
So
into our minds.
the other thing that is definitely being collected is the RT-PCR report. That is definitely centralized. Every lab is mandated to report it. So that is again being so. Anybody who's had an RT-PCR test is already in the system. If they have a positive report, 100% they are in the system. And then, of course, like Kavi says, at least admission, every hospital have at least admission.
That sounds very optimistic, Vidya. We'll take it from there.
Yeah, we also can talk with the state. They can, some of the data collected at the state level, it would be possible to get that also, to augment the analysis. And I feel that, because there's a lot of whatever we do, even little bit we do, it moves the needle a lot in terms of writing research papers, in terms of getting, grants for junior researchers to go forward. And I see many junior researchers, faculty, see machine learning work. I mean, not just India, all over the world is all about, okay, that we build this model and it may be applied someday. But here you got a chance to build models and actually apply, and in the clinical setting, applied in the clinical setting. And for junior researchers, it's a good career track to pick up right now, in at least in the low, in setting like India, where we're moving to the digital side right now. So there is a good opportunity to publish and get funding, and we should think about along those two lines in the short term as a group.
Patti, I just wanted to say, Patti, the new finance minister of Tamil Nadu, DMK gentleman, I'm forgetting his name, a brilliant gentleman in numbers, data, economist. He's an economist. He's got PhD. Superb. I heard his YouTube a couple of months ago. He's way ahead of the lot. I mean, if you have people like that in health ministry, and if you have access to him and can talk with him about how he can use that kind of informatics in health industry in Tamil Nadu, that would be a great start. He knew inside out what the economics was, what the numbers were, what the techniques are to get supply chain type of questions, how to use informatics. Superb guy. So I think you know whom I'm talking about. Try to see if you can get his blessings for the health ministry.
Yeah, we'll do that, Amit. We'll try.
Yeah, Dr. Ravi, any final comments? I think we've been here close to 2 hours.
No, it was been a very interesting discussion, and such discussions probably lay the foundation for things to start, small projects, and small initiatives, and hopefully we'd see a revolution in future. I was also thinking that maybe I should probably whisper this into my friends' ears in the National Medical Commission, saying that, only National Medical Commission made virology laboratory possible in every medical college, which was one of the things that I enjoyed most when I retired. So maybe this has to go to those years, saying that. And now, oxygen plants and oxygen generators, thanks to the second wave, we got something into the system. Maybe data should be the next one, and I'll see what I can do about it. Thank you all very much, and it was great.
Thanks.
Meeting all of you again.
Thank you, Dr. Ravi and Narayan, and thanks Shyam and Kavi for what is your working hours spending with us, and we'll keep in touch. And I can give you you already have Dr. Ravi's number, so for any follow up you can with Dr. Narayan's as well. And any sort of suggestions that come up to either me or Radha Krishna or on our Facebook page, we will relate to you. And
Thank
maybe
you so
now
much.
you should make one more push at JIPMER to join your 4C thing. Since so many things are happening now, maybe the director may be more inclined to agree to join 4C now if they weren't before. So thanks everybody, and Nalla said, I'm sure we are all vaccinated, and please take care and stay safe. We'll meet once again next Thursday with yet another episode of Marvelous Medicine. Thank you, everyone.